Thank you very much. It is my, can you see my screen?
Not yet.
Yeah, okay. Okay, should
Yes.
Great. The technology is always the part, but so it's my pleasure to be presenting today. I'm only a little disappointed that it's not in person because it is one of the, the best places to come and to enjoy and see old friends. So I do enjoy seeing everyone, and certainly hope we can do this in person in the near future. Today, I'm going to be talking about Teprotumumab, and I was asked to speak about the biologic mechanism and some about the clinical effect. And I understand that Teprotumumab is not available outside the US. But what I really want to speak about is the biologic mechanism that I think is going to be so important in the future, because undoubtedly there's going to be other agents that will be introduced that take part in this same or quite similar mechanism, and that I'm very certain that this will be available much more widespread, whether it's Teprotumumab or something else in the future. So I think understanding the biologic mechanism and the differences will be quite key. Sorry. So I am a consultant for thyroid eye disease therapies for both Horizon, Immunovant, which makes a different compound, and Viridian, which is also into the IGF-1 receptor, idea as far as therapies. So we know that, and part of this is stepping back and thinking about what are the underlying aspects, the universal theories of thyroid eye disease. Well, we've heard a lot about inflammation, tissue expansion, and remodeling in the orbit. And in general, that's kind of what we're dealing with, whether it's some patients experiencing a predominance of one or more of these aspects. And we know that this increase in remodeling, and precisely an increase in cellular proliferation and extracellular matrix accumulation, in addition to inflammation, is what leads to both the short and the long-term consequences in this disease. So I want to very simply break the disease into acute and chronic thyroid eye disease, because I think that there are overlapping pathophysiologic mechanisms here. And I think that one of the things we have to do is think about the immune system, but also think about the target tissue, which is the fibroblasts. And, as I talk about acute or active disease, it'll be, it's typically 2 years or less. It's progressive, as Peter mentioned, changing symptomatology, whether that be proptosis, double vision, inflammatory signs and symptoms, et cetera, a higher clinical activity score. No surprises to the group here. And then chronic or stable disease, again, just as you've heard it, is typically longer than 2 years, stable, non-changing proptosis and double vision. And we've often thought of the ideal therapy of introducing it early in this process, and then being relatively unable to alter the disease later on. And that does take into account many assumptions of the pathophysiology by saying that. One is that we have to think that, well, early in the disease, there is this inflammatory process that we see as clinicians and signs and symptoms, and then that fades. But remember that during the chronic process, there's also a tremendous amount of increased metabolic activity, almost a new set point by the orbital and periorbital fibroblasts that now increase extracellular matrix deposition, and they do so in waves of different extracellular matrix deposition. We've looked at the transcriptomic analysis and the gene usage of every gene that's used by the orbital fibroblast, and found an incredible array that chronic, just because it doesn't look like it's changing, is very actively turning these processes over, usually in every few days. So let's start to break this down even further into short-term inflammation, which, I think, the redness, chemosis, the typical inflammatory signs. And for most of us, I think that we have agents that will be able to help with those. We have anti-inflammatory agents, and many you've already just heard that can do quite well. What we've not been able to successfully deal with are the long-term consequences so easily, the strabismus, double vision, proptosis, the tissue expansion that's typically so characteristic of this disease. And so, one of the things that we've learned is that the anti-inflammatory processes, and maybe we're just not picking the right timing, et cetera, but there's been no placebo-controlled trials demonstrating an effect of these agents, of reversing the underlying alterations of the orbital tissue, such as proptosis and strabismus. We did a huge meta-analysis of steroids and found that the placebo-controlled trials, all by under the GO-QOL guise, were about less than 2 millimeters. They were usually about 0.7 millimeter reduction of proptosis, and with substantial side effects. So we do a very good job with the inflammatory process, but not so much with the long-term process. And that led to several years ago, molecular targeting of the antigen. So instead of just targeting the immune system, can we target the antigen or the subject of the immune system assault? And what I'm going to put forward to you for mechanism, I think, is what many of these therapies will be built upon in the future. And that is thinking about what is the target of the immune system and how does that target or the activation of that target affect both the short-term and the long-term manifestations of the disease. So fundamentally, the one thing that we've learned in the last 15 years in the laboratory is that the insulin-like growth factor 1 receptor is overexpressed on Graves' disease fibroblasts and immune cells. You take identical twins, as we did from Denmark, person who has the disease has IGF-1R overexpressed, person who doesn't does not. And consistently, of the one thing that's been the most consistent in 15 years is there are always overexpression of the IGF-1 receptor. And that signaling through that receptor mimics the pathologic findings that we see in this disease: extracellular matrix turnover, production of IL-6 and production of inflammatory molecules, activation of T cells. Everything that we've devised to inhibit also is downstream from this receptor. And that there appears to be antibodies to these receptors in Graves' disease patients and to the construct with TSH, the TSH receptor, which I'll speak about also. So the IGF-1 receptor, again, being the hallmark of Graves' disease, this is just overexpressed on T cells, and as we're showing here in Journal of Immunology now, dating myself quite a bit, but also in B cells, monocytes, orbital fibroblasts, every cell tissue that we could find in the periorbital environment, and the immune system appears to overexpress the IGF-1 receptor. So that leads us to believe that potentially this receptor is involved. And not only is it overexpressed, but it's not overexpressed in other autoimmune diseases. Here shown in Graves' disease and CD4 T cells, where in Graves' T cells, this is overexpressed, not so much in other autoimmune diseases. So it highlights the potential central role of the IGF-1 receptor. This became much more apparent a little bit later on when we found that the IGF-1 receptor actually commingles. It actually forms a molecular bond with the TSH receptor. On thyroid cells, though the TSH receptor far exceeds the IGF-1R, but on orbital fibroblasts, the IGF-1 receptor is in quite abundance, where the TSH receptor is actually quite small. But when they exist as a pair. They are receptors that bind together and are linked together, such that when you activate one, or block one, you actually block the activation of the other receptor. So for example, we were able to show that if you block the IGF-1 receptor, you not only block the downstream signaling of the IGF-1 receptor that leads to higher on-end production and extracellular matrix production, you also block the TSH receptor from producing IL-6 and from other inflammatory cytokines, all in orbital fibroblasts. So a very unique set of scenarios where these two receptors, seemingly unrelated, but are actually on the surface of the cells of interest in this particular disease, leading us to really think about, the mechanism here. So we know that in beginning to think through this over, pretty much a couple of decades, and looking and building the preponderance of evidence that if we could block this signaling of the IGF-1 receptor, maybe that would then lead to stopping or discontinuation of the IL-6 production, of hyaluronate production, et cetera. So Teprotumumab is a mechanism of action of one particular medication. You're going to see more. And there's going to be other ones that also have targeted binding to the IGF-1 receptor that will likely inhibit the IGF-1 TSHR signaling complex. And the reason why there are so many medicines made like this, by the way, just as a side, is that the overexpression of the IGF-1R was also seen in sarcoma many years ago, and also somewhat in breast cancer cells in some subtypes. And so it became a huge interest for some companies to develop anti-IGF-1 receptor blocking antibodies. It didn't do so well in the sarcoma field, and in breast cancer, it didn't deem to be worthy of following up. But there are lots of these molecules on the shelves, and I'm sure people waiting to come into this field to actually produce these. Anyway, we know the targeted binding likely of this IGF-1 receptor or of this IGFR TSHR signaling complex will likely lead to fibroblast involution, decreased proliferation, decreased hyaluronate production, decreased cytokine production. We've shown all that in the lab. And so that was the mechanism of action that led to at least the idea that, well, maybe this will work in a clinical trial and prevent the excessive growth in hyaluronate behind the eye. So here's a little bit, again, now putting that mechanism of action together. And what I want you to draw a little bit of attention to is looking at the acute thyroid eye disease or active thyroid eye disease. It depends on the terminology, but I'm not trying to split hairs. The T cells and B cells are activated in part due to the orbital fibroblast being at the center here and producing inflammatory cytokines. We know that the orbital fibroblasts also have CD40 ligand. They have a lot of ligands that activate the T and B cells. We know that stimulation of the IGF-1 receptor TSHR complex is likely central to this whole process. Still unclear exactly how and why, frankly, because I think it's a little more complicated than we think it is, but that's a different story for a different day. But leads to activated T cells. And then the downstream is that we've shown in many publications, increased hyaluronate synthesis, glycosamine glycan, increased differentiation to adipocytes, myofibroblasts, inflammatory cytokines, everything that we know as far as tissue expansion and inflammation. Now, as a setup for later, what happens in chronic thyroid eye disease? Well, we know that the tissue still overexpresses the IGF-1 receptor. There's still a process, presumably, that is relatively unchanged, but we do not see continued activation of B and T cells, et cetera. As in typical immune responses, you have an immune response, and then that immune response begins to cycle itself down by very specific mechanisms. But what we do know is that the orbital fibroblast continues to be active in producing hyaluronate, glycosamine glycans, and very other extracellular matrix molecules in very high rates. So it's almost like it has a new metabolic set point. They're almost cancer-like orbital fibroblasts that now have a new set point. And frankly, it's the only way that you can really think about and explain an involutionary process of some of the data that we'll present later, that you're actually interfering with the metabolism of the orbital fibroblasts in addition to the immune response with IGF-1 inhibition. So coming back to testing this and the clinical effects, let's go through some clinical data. Well, we know that Teprotumumab in the treatment of the eye disease, this was published in the New England Journal. There were 2 phase 2, phase 3 trials that we headed, and looking at primarily active thyroid eye disease. The reason why we chose active thyroid eye disease is that if we took a poll here, everyone would agree, let's do active disease, not late stage disease, and we're going to do Teprotumumab versus placebo, because there's been very few placebo-controlled trials, and it appears worthy that if we're going to have a natural history of disease that improves, we should have placebo. The most important thing, was the primary endpoint, and that was an improvement in the disease outcome, meaning at least 2 millimeters improvement in proptosis, plus various degrees of improvement in double vision. Because we have so many great treatments for inflammation and for reduction of clinical activity score, plus the FDA didn't want to hear anything about reduction of clinical activity score. They only wanted to know about improvement of long-term disease and proptosis. So the summary of results pretty much of both trials were that the primary outcome of proptosis responders, meaning the percent of patients with at least 2 millimeters reduction in proptosis from baseline, was significantly greater with Teprotumumab than placebo. And and I'll show you the data, and it was quite dramatic. And then all secondary endpoints were also met, meaning that the clinical activity score went down in a preponderance of patients to 0 or 1 by the completion of treatment. The patients improved in diplopia, and the mean change in proptosis was also very different. And also the quality of life scores were different. The FDA really only wanted proptosis, so that's why these were the secondary endpoints. This is a placebo patient pre-treatment, week 24. You can see that there's probably a little worsening of this disease process, certainly not improving. Here's a patient who had pre-treatment versus post-treatment and about a 5 millimeter improvement. These are patients who were published. And at week 24, an improvement of the proptosis. And I'm sure most people are familiar with this. So a dramatic improvement in the proptosis. And we also measured volumetric muscle expansion, showing that both the muscle size, the volume of the extraocular muscles, and of the fat both decreased during this time period. Here's the clinical activity score reductions. You can see in the gray that the natural history is that the clinical activity score improves. Here, within 24 weeks of patients who are diagnosed 9 months or less, by at least 2 points, an improvement much more with Teprotumumab. And 60% of patients treated with Teprotumumab had absent clinical activity scores of 0 or 1 by the end of the study. They all had to have 4 or greater to be enrolled. Proptosis response, a reduction of greater than 2 millimeters. You can see the response rate seems to plateau, possibly due to the patients are having improvement. Once you get to about 80%, it begins to plateau at week 18 to 24. This is based upon an intent to treat analysis. So if a patient missed an appointment, if they missed the week 24 because they couldn't make it in, they were considered a non-responder. So this is a very tight analysis. And the number to treat, meaning an intent to treat analysis, which means how many patients do you have to treat to get a response, was an amazing 1.3. It's almost unheard of, for some of the, medications that it's so low, because normally you have to treat a lot more patients to actually get a response. Proptosis reduction tended to be right around a little over 3 millimeters. It was about 0.5 millimeter in the placebo. And then at week 24, you could see about 3.3 millimeters improvement in the New England Journal. And not overall surprising, if you have reduction of proptosis, we've now demonstrated extraocular muscle reduction. We've published upon this separately. Both it appears to be an improvement of the inflammation in the orbit, but also the size of both the fat and the muscle compartments. The diplopia response was measured via Gorman because it was a multi-center international trial, and there's a dramatic improvement in diplopia. Of at least 1 grade, then those were considered responders at that point in time. Also, approximately over 50% of patients had complete resolution of their diplopia. So we can see that effects at 24 weeks certainly very good. The overall quality improvements, again, both facial appearance and vision, both very good. The safety profile appears to be very good. Even in the real world, safety profile treated quite a number of patients, appears to be similar, and we can talk more about that, but it appears to be very reasonable. There are a couple that I think certainly for inflammatory bowel disease, for diabetes, have to be very careful. This is still a biologic. Even though it has a good safety profile, people still have to be careful, and what I find is you just have to be very careful in your use, not indiscriminate. So what is the durability of response? And this was very recently accepted to the Lancet. I'll give you a sneak preview of this. And it appears that the durability, meaning the proptosis responders, diplopia responders, I told you that they were about 83 or in the 80%. This is from both trials. After 60 weeks after initiation of therapy, meaning about 40 weeks off of treatment, they're still 87 and 88%. For proptosis responders. So, it appears to be quite a durable effect in most patients. And again, this is still an intent to treat analysis. So, we're still following patients for this period of time. Diplopia responders also appears to be quite durable. With 66% at week 7, actually even went a little better, maybe even with the natural history of an improvement over time, was up to 78% of diplopia responders. The complete analysis, as I said, will be out very soon in that journal. So how does Teprotumumab also reverse chronic thyroid eye disease? And I don't know if Jeff Rose remembers, but I bet him a beer about 5 years ago that this would be possible. But how is it possible? How can you actually reverse disease that's been going on for longer than 3 years, has low clinical activity score? Everyone in this room would call those patients stable. What comes back to that same pathophysiologic understanding of the overexpression of the IGF-1 receptor. We demonstrated this recently in a non-inflammatory study, but the single most important thing is that the IGF-1 receptor maintains overexpression in inflammatory, non-inflammatory, and chronic compared to controls. And it appears to inhibit the metabolic turnover of extracellular matrix molecules. And it appears to reverse chronic thyroid eye disease. Again, just coming back to that diagram, just so that you can see that turnover. We see about a greater than 3 millimeter reduction in proptosis in patients who are chronic and who have chronic thyroid eye disease over the course of this treatment. We have about 30 of these patients, so we have from a multi-center analysis. This is just an example of a patient on the left with view and then on attempted up gaze. They proves double vision. This patient had the disease for over 6 years, absolutely did not want surgery. She had it and it made an improvement. We're also looking at and will show the improvement in the volumetric scans on patients with chronic disease. Again, I think this efficacy compares reasonably to decompression surgery. We seem to uniformly be getting over about 3 millimeters in active, chronic, et cetera. The conclusion of it is that we really have to sit back, and this is our first entree into the biologic world of a disease-specific biology for thyroid eye disease. And in dealing with the mechanism, there's a lot of things we don't know, but what we do know is overexpression of the IGF-1R is a hallmark, and the signaling cascade of this receptor complex appears to be critical. And chronic is not so quiet. Chronic, there's a lot going on underneath the surface, especially as far as extracellular matrix deposition, and we'll have a lot more on transcriptomic analysis to determine that. But thank you very much for allowing me to speak, and really look forward to the other